My name's Ben Butler. I'm an orthopedic trauma surgeon for Northwestern Medicine. My practice is primarily focused on fracture care. I do that mostly in the acute phase, at the time when patients are injured. I also deal with the complications associated with those injuries, including infection, deformity, and non-unions. At Northwestern Medicine, I am known for acetabular fracture surgery, as well as fractures of the pelvic ring as a whole, not including the hip socket. In addition to that, I am known for limb reconstruction, meaning taking care of large bone defects that result from infections or trauma in the femur and the tibia. Trauma care in general is a multidisciplinary field. Certainly orthopedic trauma is as well. We work closely primarily with the general surgeons who are responsible for stabilizing patients and dealing with their intra-abdominal and intrathoracic injuries. We also work closely with the vascular surgeons with injuries that affect the bones, but also the large arteries and veins. We work very closely with the plastic surgeons because many of the injuries we deal with involve loss of muscle and skin. The majority of my research focuses on patient outcomes. Recently, I have focused particularly on the outcomes after gunshot wounds as compared to similar fractures resulting from what we call blunt trauma, things like car accidents or falls, how gunshot wounds differ and how they are the same. In particular, the rates of infection for these fractures may be higher than we previously recognized, and I would point to recent research by others in tibia fractures in particular. So myself and my partners have focused on some of those injuries, trying to determine what exactly is the actual infection rate of some of those injuries, and what are some predictors of infection or other poor outcomes. I also do a fair amount of research on resident education. In other words, how to best train surgeons to become competent and safe when they're out in practice on their own. Complex hip and pelvic fractures require some of the most technically demanding approaches and techniques that are known to orthopedic trauma surgeons. For hip socket fractures, that is acetabular fractures, the goal is to get the patient's fracture back into perfect alignment in order to prevent arthritis of the hip joint. To do that often requires very large approaches that we can physically manipulate those fracture fragments under direct visualization. For pelvic ring injuries outside of the hip joint, there's much more opportunity for minimally invasive surgery. So for many of those injuries, we can accomplish the goal of restoring the patient's anatomy through incisions that are 2 centimeters or less in size. Ultimately, the goal of fixing complex pelvic and acetabular fractures is to restore the patient's normal anatomy. While there are a great number of techniques described for doing that, I would not consider those to be in contrast or in competition with each other. Instead, I would consider those techniques to be complementary. It's up to the surgeon to determine in which cases, which techniques would be best for restoring the patient's normal anatomy, which will give them the best possible outcome. I think at Northwestern Medicine, we have a fantastic team. We discussed the multidisciplinary approach to trauma that we use with respect to surgeons, but we also have incredibly talented and comprehensive support staff here as well. We have nurses, physician's assistants, social workers, and physical therapists who are all some of the best in the city, in my opinion, and who help us deliver the best possible outcomes for our patients.